Bismillahirrahmanirrahim. Assalamu alaikum, dear students. Today we are going to study a very important topic, which is normal labor. In order to understand the pathology and abnormal labor, you should first know what is normal labor and how will you manage a patient with a normal labor. In today's lecture, you are going to learn about the definition of normal labor, what are the factors which influence the progress of normal labor, diagnosis of labor, what are the stages of labor, and how will you manage the labor. This is just an outline and not in too much detail. The definition. Labor is defined as the onset of regular painful contractions with progressive effacement and dilatation of the cervix, accompanied by descent of the presenting part, leading to expulsion of the fetus or fetuses and placenta from the mother. This is the standard definition taken from your textbook, which is 10 teachers, and you should learn this definition word by word by heart. Whenever there is a problem in any one of these three P's, then we can say that it is dysfunctional labor or any abnormality in labor, and we have to rectify that abnormality. If power is insufficient, like if uterine contractions are not sufficient, then rectify that. Passenger means the fetus. It's the duty of the doctor or midwife to assess whether the passenger is of adequate size, good size, normal size, can pass the pelvis or not. Like for example in GDM you can see usually the babies are of good size. Approximately the weight is more than 4 kg, 4 to 4.5 kg, then it's difficult for that baby to deliver normally. So this is the duty of doctor or the midwife to assess it. We can estimate the fetal weight by clinical examination as well as by ultrasound estimation of the fetal weight, and also the presenting part or presentation of the fetus. If the presentation is cephalic, okay, it can deliver vaginally or breech. Longitudinal, cephalic or breech can deliver vaginally, but you have to assess it whether we can deliver it or not. In previously it was told that breech cannot be delivered vaginally, but now the guidelines they say if you have adequate training in delivering the breech baby, you have sufficient trained doctors who can do the breech delivery, then we can go for vaginal breech delivery or assisted breech delivery. If there is any malposition or malpresentation, then definitely we cannot opt for the normal labor and we can do the cesarean section. Passage. The passage is very important. Passage is the bony pelvis. There are various ways to assess whether the pelvis is adequate. The bony pelvis has adequate space to pass the passenger to deliver the fetus. There are landmarks in assessing the passage or the bony pelvis, which tell us whether the pelvis is adequate or not. We can further elaborate it in our upcoming lectures. They will tell us how we can assess the passage or bony pelvis is adequate or not. The female pelvis, it is the basic framework for the birth canal. True pelvis consists of inlet, cavity and the outlet. The fetus must pass through all the three in order for labor to be successful. There are 4 types of the pelvises: gynecoid pelvis, anthropoid pelvis, android pelvis and platypoid pelvis. As in this table you can see there are various properties of all the 4 types of pelvis. The gynecoid pelvis is a normal type of the pelvis which is usually present in more than 50 to 70% of the women. It is round shape and it is a normal pelvis which helps in delivering the baby. The android pelvis or male type pelvis is heart shaped, and with this we cannot deliver the baby vaginally. Anthropoid pelvis, this is a oval shaped pelvis, and it causes the persistent occipito-posterior position or persistent occipito-anterior position and can lead to obstructed labor. And the platypoid pelvis, it is flat type. Usually baby can deliver vaginally, but it can lead to obstructed labor as well. So this is the fetal skull. You can see the various landmarks on the fetal skull. From anterior to the posterior, this is the frontal sulcus, frontal bones, coronal suture, anterior fontanelle, the bitemporal diameter, the sagittal suture you can see, and then the parietal eminences and the biparietal diameter, which is usually 9.5 centimeter, posterior fontanelle, occipital bones, and the lambdoid suture. These are the typical anteroposterior diameters of the fetal skull. You can see the largest diameter is occipitomental, which is 13.5 centimeter, and it cannot be delivered vaginally. The normal diameter which can be delivered vaginally in a normal gynecoid pelvis should be 9.5 centimeter or less, because the distance between two ischial spines is not more than 10 centimeter. So the diameter which should pass through these ischial spines should be less than 10 centimeter. The occipitofrontal is usually it is in the broad presentation, which is 11.75 centimeter. Submentobrachmatic 9.5 centimeter, it can deliver vaginally. Suboccipitobrachmatic, which is the normal position of the fetus, the presenting part, it is the 9.5 centimeter, and it can easily pass through the ischial spines and can deliver vaginally. What are the causes of the onset of normal labor? Usually the following theories are proposed: hormonal factors and the mechanical factors. The estrogen theory, progesterone withdrawn theory, prostaglandin theory, which says when the cervix stretches, it releases the prostaglandin, which starts the process of labor. Oxytocin theory, which says when there is onset of labor, the posterior pituitary releases the oxytocin hormone, which results in the uterine contraction. Fetal cortisol theory, that the fetal adrenal glands release the cortisol, which starts the cascade of the normal labor. Mechanical factors, uterine distension theory, and the stretch of the lower uterine segment, which causes the progress of the labor. So this is our diagrammatic representation of the progress of labor, and you can see how the fetus, the fetal membranes and placenta and mother, they are interrelated, and there are the multiple factors showing the start of the labor, how they influence the start of the labor and the progress of the labor. Here you can see in the fetus, the hypothalamus, the corticotropin releasing hormone acts on the fetal pituitary, which causes the fetal adrenal glands to release the cortisol. The cortisol, it affects the placenta, and the placenta, in it there is the increased oxytocin, increased prostaglandins, increased estrogen, progesterone is decreased, and interleukins are released, which help in the progress of the labor. And in the mother, you can see the hypothalamus acts on the posterior pituitary to release the oxytocin, and in turn the oxytocin increases the myometrial receptors in the uterus, which cause release of prostaglandins and increase gap junctions. The prostaglandins are released, and there are also stretch receptors which increase in number and sensitivity, and then cause uterine contractions, which leads to the progress of labor or the onset of the labor. So you can see all these factors are interrelated. How will you diagnose clinically that the labor is started? There are the certain signs show, which is the evidence by mucus mixed with the blood or the mucus plug, which is released when the labor is going to start. Sometimes there is rupture of membranes in which the liquor is released. The painful regular uterine contractions which results in the dilatation of the cervix give a clue about the diagnosis of the labor. There are 3 stages of the labor. The first stage of labor, it begins with the onset of true labor contractions and ends when the cervix is fully dilated, that is 10 centimeter. The cervical effacement and dilatation occurs in this stage. And we can further divide the first stage of labor into 2 phases, the latent phase and the active phase. From the diagnosis of labor to 3 centimeter dilatation is called as latent phase of the labor, and the active phase of first stage of labor is from 3 centimeter to the full dilatation of the cervix. The second stage of labor begins with a complete dilatation and ends with the delivery of the baby. It is approximately 2 hours in a nulliparous woman and 1 hour in a multiparous woman. When in a nulliparous woman 2 hours have passed, and second in 2 hours are passed in the second stage of labor, now it's time to take the action and to assess what is the problem with passage, passenger, or the power. And it's time to take the action. And in multiparous women, it should not prolong more than 1 hour. The third stage of the labor, it begins with after the birth and ends with the expulsion of the placenta and the membrane. It is the shortest stage, and it usually up to 30 minutes. And if it takes more than 30 minutes, then it's time to take the action. You can opt for the manual removal of a placenta, and definitely it can cause further problems like PPH infection. So it should not be more than 30 minutes. Management of labor. How will you manage? When at the time of admission, review the antenatal record of the patient. Take complete history if record is not available. Rule out all the risk factors present. Do the general physical examination of the mother, her general condition, pallor, edema, abdominal scars, maternal height. The maternal weight is very important, because increase in weight, increased BMI can cause difficulty in delivering the baby and can cause also shoulder dystocia and dysfunctional labor. Abdominal scars, look for any previous surgery if there is any previous cesarean section scar or any uterine surgery, then do not do the normal vaginal delivery, because it can cause the rupture of the uterus. Record the vital signs of the mother, blood pressure, pulse rate, her respiration, her temperature. Auscultate her heart and lungs. Look for any pathology. Urine analysis should be done, in which you can see the proteins, sugars, and ketones. Abdominal examination, you do the detailed examination, determine the fetal presentation, whether it is cephalic or not, whether it's, what is the position, and engagement is present there or not. Auscultate the fetal heart sounds. Evaluate the uterine contractions. If they are adequate, okay. If they are not adequate, you can add oxytocin to augment the uterine contractions. You can attach cardiotocography or CTG for the 20 to 30 minutes trace of the fetal hearts to look for any bradycardia, tachycardia, or rule out any fetal distress. Vaginal examination, we usually do the vaginal examination to confirm the degree of dilatation and effacement of the cervix, identify the presenting part and the station of the presenting part, fetal head engagement if there is any doubt, confirm the membranes are intact or not, and you can also do the artificial rupture of the membranes if needed and exclude the cord prolapse. Bladder and bowel care, administer an enema, allow to empty the bladder every 1.5 to 2 hours. Nutrition in early labor. No food after labor is established to prevent regurgitation and aspiration. Place IV to start administration of the fluids. Positioning of laboring mother. Once everything is well with mother and the baby, patient may ambulate or lay in bed as she feels comfortable. The monitoring or progress of labor and also give the pain relief. For the pain relief, you can give opiate drugs, intramuscular pethidine can be given. Epidural analgesia is the ideal pain relief during labor. Partogram. A partogram is a composite graphical record of key data, that is maternal and fetal, during labor, entered against time on a single sheet of paper, and it monitors the progress of labor. There are relevant measurements such as cervical dilatation, fetal heart rate, duration of labor, vital signs, and uterine contractions on the partogram, which can show you whether the labor is progressing normally or not. So this is the partogram. You can see this is the graph usually present and attached to all the charts of the laboring patient, and at the top you can see there is the fetal heart recording, and then there is the second graph shows the cervical dilatation and the station of the presenting part. The third one, in which you can see the dark or a black color filled blocks, they show the uterine contractions and their uterine contractions, whether they are adequate or not. And in the end you can see the vital signs, the blood pressure and pulse of the mother. This is the picture in which you can see in the stage 1 dilatation, the cervix is undilated cervix, and from the undilated cervix to the fully dilated cervix, which is 10 centimeter in diameter. And stage 2 is the delivery of from the full dilatation of the cervix till the delivery of the baby. This is the stage 2. And in our upcoming lectures, I will tell you about the mechanism of labor, how the baby or fetus undergoes various movements, head movements, skull movements, body movements to pass through the passage bony pelvis. And the stage 3 is from the birth of the baby till the delivery of the placenta. You can during labor continue care, fetal and maternal well-being, monitor fetal heart rate, maternal vitals, observe whether the labor is progressing normally or not. Adequate pain relief should be given, adequate hydration to prevent ketosis, and you can give ringer lactate solution during labor to prevent the dehydration. Third stage begins with fetus delivery and ends with delivery of the placenta and the membranes. There are two stages of the third stage: the separation of the placenta and expulsion of the placenta. It should be 30 minutes or less, not more than 30 minutes. And the average blood loss is around 150 to 250 milliliters. The signs of separation are globular and hard uterus, sudden gush of the fluid, and the cord lengthening. These are the signs which tells us about the delivery of the placenta. Active management of the third stage of the labor. This is very important to prevent the postpartum hemorrhage, and this includes use of oxytocin. Oxytocin, usually 10 units, are given IV around the time of the delivery of the anterior shoulder. Controlled cord traction, uterine massage. Per rectal misoprostol 600 to 800 microgram stat after the delivery of the placenta to prevent the postpartum hemorrhage. And the latest is injection tranexamic acid IV stat can be given, 1 gram IV stat can be given to prevent the postpartum hemorrhage, and it is the latest trial, which is known as the women's trial, and it was conducted from 2010 to 2015, and in that they concluded that injection tranexamic acid is very helpful in preventing the postpartum hemorrhage. Thank you. So it was today's lecture, and I hope that you have understand very well about the labor, how it starts, what are the stages of the labor, and how you can manage a patient with in normal labor. So, inshallah, in our upcoming lectures, we will also discuss the abnormal labors and how can deal with that. Thank you.